Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
Please join me in welcoming our distinguished guests, Senator Hinojosa, Dean Krause, Representative Longoria, and Congressman Baylor. So I want to begin by talking about the state of healthcare, Senator Hinojosa. As the veteran, 30 years in the legislature in one form or another, you know this part of the state and this issue as a policy issue better than just about anybody. The state of healthcare in the Valley. Texas is a profoundly uninsured state, number one in the country in the number of people and the percentage of its citizens without health insurance. The Valley, generally speaking, has double the uninsured rate of the state and triple the uninsured rate of the country.
Correct.
We know that the Hispanic population in the Valley, and the Valley is profoundly Hispanic as far as the population goes, tends to be more uninsured than the Anglo population here and elsewhere. And we have a shortage of doctors in the state. I want to talk to Dean Krause about this specifically in a moment, but we have more of a shortage of doctors in part of the Valley than we do in the rest of the state. I'm tempted to ask you, is it as bad as the numbers suggest, but I'm afraid I know the answer.
Yes, it is. It's even worse than that. Quite frankly, here in the Valley, we face many challenges because we're right next to the border with Mexico. Number one, we have the highest poverty rate in the nation.
Yep.
Somewhere around 38% of the population is in poverty. Number two, 50% of the children here in the Valley are at the poverty level. I guess number three, the uninsured rate here in the Valley is about 50%. And we have an epidemic of diabetes, obesity. We have heart disease. So we have a lot of challenges.
Right.
In addition to that, many times people don't realize that here in the Valley, we provide healthcare services for many people in Mexico.
And people cross the border to come get health care here.
They cross the border and have babies here, or many of them also live here.
Yeah.
I think one of the untold stories is what is the number of people, what percentage of our population are actually undocumented? I always talk about the area between the border and the checkpoints, USA, Tex-Mex. Because we have a lot of Mexican nationals that live here in the Rio Grande Valley who are not U.S. citizens or legal residents.
Right.
So we also provide health care for them. So the challenges that we have are many.
Yeah.
And of course, for us, the unemployment rate has gone down quite a bit, but the reality is that many are not aware of the Affordable Care Act and don't know how to apply. And if they do apply, it's too expensive.
And as you know, Senator, the state didn't make it easy to enter the Affordable Care Act, did not embrace the federal exchange, the state exchange model, didn't encourage people to apply, didn't expand Medicaid back when the time came.
Well, on the contrary, at the state level, we also are struggling with our budget. The amount we spend on health care is about 80 billion, about
Yes.
80 billion plus, almost 40% of the state budget. Medicaid alone takes about $66 billion.
Yes.
Over a third of the state budget. And at the same time, we have a lot of issues because of the uncertainty of what will happen in Congress with 1115 waivers and they talk about block grants. So there's a lot of uncertainty in the healthcare area.
Well, I want to come to the federal thing with the congressman in a second. I want to go to Representative Longoria, though, because as you are Vice Chair of Finance, he's Vice Chair of Appropriations. You two understand the budget as well as anybody in the Valley. And what Senator Hinojosa said, Representative Longoria, is true, that health care is taking up an increasing part of the state budget every 2 years. In fact, I believe that it has now risen to meet or even go beyond what we're spending on education, right, at the state budget level for the first time in history.
Yeah, I think so. Whenever you talk about healthcare, it's the big gorilla in the room.
Right.
It seems to suck out all the air. What I like to look at is we have our Medicaid population, you have Medicare, you have CHIP, but the folks that don't qualify, it's important with the expansion of ACA, whatever was expanded. But I think the system's broken because we have a gap of folks that don't qualify for any subsidies.
Not quite poor enough.
Yes,
right.
Exactly. So I actually went on healthcare.gov right before I got on here on this panel, and I think it was $103,000. And if I click on that, I make over $103,000, then I don't qualify for any type of subsidy.
Right.
Well, what happens? You apply, and your premium's astronomical, looking about $2,800 for a family of 4, and folks can't afford that.
Right.
So where do those people turn?
When you say that the system is broken, though, Representative, you prefer it to the alternative. You're glad that there's an Affordable Care Act.
Well, I think it's not perfect, but at the same time, we need to make a lemonade with the lemons. We need to look at it and see what's working, see what's not working. It's impossible, I think, to revamp the entire system.
Right.
But we need to make sure, what can we do to make sure we insure as many people as we can? Because at the end of the day, healthcare is fundamental.
Yeah.
And I think it's one of those things where we like to say it's complex, but I think we say that because we want to kind of detract from it and not have to deal with it. But I think over time, working with the federal government and see what they go ahead and send down to us, we need to work with that. But we need to make sure we expand it. And I think it's important for folks to realize that whenever you talk about healthcare, it's really not political. We need to make it purely policy-based.
Yeah. Dean, I said earlier that we have a problem of not enough coverage in Texas, but we also have a problem of not enough docs in Texas. Federal government designates certain parts of the state health professional shortage areas, not enough doctors. They do this in terms of primary care, they do this in terms of dental care, they do this in terms of mental health. Texas is near the top, by which I mean nearly the worst, in terms of the number of doctors that we have for the citizens that we have.
Very true, and not only is Texas among the worst, this part of Texas is even worse than the rest of the state.
rest of Texas,
We have
right.
among the worst primary care to patient ratios in the country. So what
Right.
that means is we simply do not have enough primary care physicians to take care of the needs.
Right.
So you have more and more people who go without care. Or if they go without care, they'll
Right.
go later in the course of their disease before they're diagnosed. And now something that could have been taken care of at a lower cost will cost quite a bit
Right.
more
Always
than if we
cheaper
had
on
earlier
the
care.
on the front end.
Absolutely. It's always cheaper to prevent than to treat. So
Right.
to the extent we can get people care earlier,
Yeah.
it will decrease the overall cost of care.
So the specifics on this are there are about 8 million people who have no access to mental health care in terms of docs available to them in Texas. There are 4 million who have no access to dental care. There are 5.5 million who have no access to primary care. This is out of 28 million people. It's a shocking percentage of our citizens. 35 of the counties in Texas have no doctors at all. I mean, a medical school like the one in the Valley, which you're now running as of the last couple of months, that is part of the solution, but you can't do this alone.
It's part of the solution, but again, our funding is woefully inadequate to take care of all of our needs.
Right. Whose fault is that?
Oh,
Name names.
Name names. It's a broad combination. We certainly need to have a partnership of state funding,
Yeah.
of local funding, of county funding, of
Right.
city funding, of federal funding. It really is putting together a patchwork of all of those, and each of those stakeholders must contribute to the solution.
Yeah, but it's not happening.
Not completely.
Not enough. Congressman, you're involved in a series of conversations at the federal level now about the future of health care, not just in Texas, but in the country. Most recently, whether or not the tax reform or tax relief bill or tax increase bill, depending upon how you look at it, will contain some kind of elimination of these subsidies. We're talking about health care even if we're not actually talking about health care primarily. You've heard these guys. You know the situation. You think the system is broken? Are you satisfied that the system is broken?
Well, let me start out by saying that you can't defy the statistics that you and Senator Hossa alluded to.
They are what they are.
They are, but for those of us who were born and raised here,
Yeah.
I have to say that with respect to the number of doctors and access to health care, that things are incrementally better than they were. They're not perfect, and we have
Right.
a long way to go.
Right.
But I think over time, as people that were born here, raised, gone to medical school, and come back, it's really improved, albeit slowly,
Right.
the access to health care and the quality of health care here in the Rio Grande Valley.
Yeah.
But I
But
think,
of course, the population's growing fast, and the question is, can the improvements keep up with the growth in population?
well, that's why I think that the work that was done by our state legislators on the Senate side and the House side to make the medical school happen
Right.
is so significant. And I think over the long haul, that, and many of us may not be here when we really begin to see the benefits of that decision I think it's going to be transformative.
Yeah. Talk about the status of the repeal effort. So the president campaigned on repeal and replace, or repeal and don't replace. Repeal was always part of it. It sort of changed what we were going to do after we repealed. Many of the people who are now running the U.S. Senate and the U.S. House likewise campaigned on that. So far, they haven't been able to put the ball over the finish line on that. Where are we right now? Where do you think we are?
Well, we're in a really bad spot. The fact of the matter is, after the 2010 implementation or passage of the Affordable Care Act implementation was actually later. The Republican majority approach was an all or nothing. It was let's repeal and replace it. And they tried to do it, but Obama was in the White House, so that was going to be impossible.
Because he'd veto anything that they sent.
Exactly. So, fast forward to this last year when all of a sudden they controlled the House, the Senate, and the White House. It was easy to try to replace, but if you have to repeal, but if you have no replacement plan,
yeah.
What happened is exactly what you would expect, which is the situation basically just blew up, and that's why we're at a point where we spent the first 7 months of this year focusing on an effort that led us nowhere.
Yeah.
I mean, the fact of the matter is that everybody agrees there are provisions of the Affordable Care Act that need to be worked on, lower drug prices, the cost-sharing reduction payments, and to the extent that some states have not expanded Medicaid, that's really important. So if we could spend all our time working towards those three things, I think we would be able to make the Affordable Care Act better.
But is your bet, Congressman, that if we were sitting here a year from now, that the Affordable Care Act as we know it today would still be in place?
Yes, except for the fact that we don't know what's going to happen with the Senate tax reform measure, and it's because it's not even final yet. But
yeah.
We don't know what's going to happen with respect to the elimination of the individual mandate.
Senator Hinojosa, Representative Longoria, back to the state piece of this and the budget. Economic Policy Institute says that if the Affordable Care Act is repealed, the percentage of our population that is uninsured will go up by 56%. 2.5 million more Texans will be uninsured if they do this. Now, the solution, Senator, is they say block grants. We're going to give you a bunch of money, and then you all go and figure out the solution. It's not going to be cookie cutter. What's the argument against us getting our money back and designing a solution that's appropriate for Texas?
I don't think block grants is the answer. Quite frankly, it will not be enough to cover the cost for health care here in Texas. And block grants would shift the cost over health care to the state of Texas. And quite frankly, it's a joint responsibility with the federal government.
You wouldn't give up? You wouldn't take on additional cost for having more control over the solution, over the outcome, particular to this population?
No, what we need is more flexibility. I think if we provided flexibility, we could make adjustments on Medicaid, how we provide services, whether we may require co-pay, $3, $5.
Yeah.
And trying to focus on long-term care in terms of trying to educate the public about how to eat healthy. We have the Healthy South Texas program here in the Valley,
right.
To try to change behavior. But I just don't think block grants is the answer. We just need more flexibility at the state level to be able to experiment and make some adjustments and changes in our healthcare system dealing with Medicaid. But I just want to also add on something that was mentioned about the medical school. We are a medically underserved area.
Yes.
But the medical school itself is a game changer for us in terms of healthcare and nurses, in terms of primary care doctors. But one thing we did at the state level, we funded residency slots at 101%, which used to be a problem. We used to educate medical students, then they go up to California, Illinois, New York, and wouldn't come back.
And they don't come back.
They don't come back.
Right.
So for us now, we have, I think, 138 residency slots here in the Valley. There'll be around 200 plus by 2018 next year. So for us, that's a big changer in that studies show and history shows the majority of doctors stay and practice medicine in the place where they
Go to medical school.
conducted their residency.
And so if you had access to more resources, you think that actually even more residency slots than we have now would be a good thing to do?
It would be a good thing because,
Right.
the practice of medicine is very, very complex. It's not just primary care doctors. You also have a lot of specialists. So they require different type of residency slots from different hospitals. So you need more, quite frankly, more residency slots. So we can also attract doctors from other parts of the country. We made it much easier to accept doctors from Oklahoma, Nebraska, other states in the country,
Right.
And expedited the process. Trying to address the problem of shortage in healthcare. When you go back to, and I'm switching around to the block grants, to us, at the state level, if we don't get some flexibility in terms of how we provide and distribute Medicaid dollars, and we do not keep the 1115 waiver, it's going to be a tremendous challenge because the cost of Medicaid right now is not sustainable.
Yeah.
At the budget that we have in the state of Texas, which is $217 billion.
And it's eating into other things. Any dollars you spend on Medicaid, you're not spending on public education. You're not spending on roads, right? These are choice dollars, not referendum dollars, right?
I mean, and that's correct. So we need to take a multiple approach to try to deal with the healthcare issues. It's not just the cost involved, which is very real.
Right.
But look, for us here in the Valley, we even created the LPPF, which is called the Local Provider Fund, the Local Provider Participation Fund, where you have the hospitals assess themselves a fee, and then they use that fee to draw down 1115 waiver funds from the federal government through the county. So we have to improvise. We did that here in the Valley. Now other regions of the state has adopted that same process.
Yeah.
So we're trying to be innovative. But one of the key things is to remember, and I'll stop after this, is that it is not just taking care of paying for health care. It's trying to focus on changing the habits of people, how they take care of themselves physically, what foods they eat, healthy foods, and cut down on a lot of the other greasy foods that create diabetes and obesity.
Yeah. Health factors on the front end affect health outcomes on the back end. Representative Longoria, let me ask you a version of the same question. So, Senator Hinojosa says we want more flexibility. Well, the ultimate flexibility would be for a stork to fly over the Capitol with one of those cartoon bags of money with a dollar sign on it and just drop it on your doorstep, and then you have all the flexibility you want. Spend that money however you want. You know that the people who run the state of Texas at the moment hate the federal government even more than they hate California, right? It's close. Yeah. It's close. They want nothing to do with the feds. They want their money back. They want their control back. Why is that not a good answer for Texas?
We want our money coming back to the state. I think that's first and foremost.
Right.
But whenever you look at the idea of a block grant, if it was perfect and it was implemented perfectly, which things are far from perfect, it would work. But at the end of the day, we're committing ourselves to a block of money to be able to deliver the services that we've been delivering, and to the extent, and I guess even we need to exceed the services that we're delivering right now. It kind of puts us in a tough predicament.
Do you think we have the capacity to deliver on that?
I
ourselves?
think we're optimistic we are, but I don't know if we can truly do it.
Yeah.
There's one of those things where we say, well, if we get more money than what we're getting now, we might as well take the block grant. Well, yeah, if we implement things perfectly and everything works, it's great. But if it doesn't work, then I think we're looking at a very dire situation. And I think for the federal government, it's easy to kind of give a block grant because you're going to commit, this is what you're going to get, here's your check, you guys administer the money.
See you at the Christmas party.
See you guys later. It makes things easier for them. But as a state, what are we going to do with those resources, and how are we going to allocate them? There's so many gamuts, and there's so many factors that come into healthcare, and we need to make sure that everybody's provided the services that they're being provided now.
Yeah. Yeah, Congressman, that's kind of the challenge here, So on the one hand, you think that the politics for the federal government are much easier. As Representative Longoria says, we're going to write you a check and we're going to be out of it. And then you guys go figure it out. The flip side of that is if you have a president whose politics you don't particularly like, which happens to be the case right now, famously, you're no longer dependent upon the whims of a president you don't agree with. If they give you the money back and you control it, then you don't have to actually deal with them. Right? Isn't there something good about that?
I don't know about that, but back to Chewy's point on the flexibility.
Yeah.
The Senate bill, the Alexander Murray bill, which is
Yes.
actually the one bipartisan bill
Yes.
that has been produced out of committee and restores the cost share payments
Yes.
that the president took away here a few months ago, actually addresses the flexibility issue, not so much with the 1115 waiver, but on the 1332 side, which is the individual and I think the small business markets.
Yeah.
The idea there would be to provide more flexibility to the state. I think they call it the state innovation waiver.
Yeah. I'm thinking about what Representative Longoria said, that, are we really in a position to provide these services even if we get the money back? I'm thinking about subsets of the overall healthcare problem, and particularly care for children. You voted against in the last couple of weeks, the effort to restore the CHIP funding that was initially not authorized, not because you disagree with the CHIP program, but because they robbed money from something else that was...
Right, out of the Medicare program. And
Right.
so many of us who support CHIP and community health centers, it was
Yeah.
a very tough vote
Right.
for that reason. But we are hopeful, albeit knowing that it's risky,
Yeah.
that the Senate will fix it. Senator Stabenow and Senator Blunt have a bipartisan bill that takes the Medicare cut out of the equation.
Finds the money from somewhere else.
And brings us a clean
Right.
Reauthorization of both CHIP and
But
community health centers.
this is the point. 60% of the children in Hidalgo County have health care that is somehow connected to CHIP and Medicaid. 65% in Starr County. This is compared to 45% statewide. Another way in which the Valley is different from the rest of the state, more heavily reliant on CHIP. If all of a sudden the federal government were out of the business of providing health care to us, just gave us our money back, could we adequately serve those kids? That's a question.
Yeah, I mean, like I said,
Yeah.
it's a little bit risky, and we're a month away. I mean, the congressional session ends on December 15th.
Right.
But we're quite confident that the Senate is going to pass something reasonable, and that by the end of the year, CHIP and community health centers will be reauthorized.
So your hope is that the Senate will come and save you.
That's right.
You're an optimist, obviously. Here in the holiday season, you
Yeah.
believe in magical thinking.
But I also think that when you look at the reauthorization of CHIP and community health centers historically,
Yeah.
and I've only been in there 5 years, but that is one of the few places where, at the end of the day,
Yeah.
the parties do seem to come together, and so.
Yeah, maybe so. Dean, you come out of a different thought process or a different tradition than these guys do, in that they're in politics and you're actually in the practice of medicine. If you were given the opportunity to design a system that would work better, could you do it?
That's such a difficult problem. And you look at all of the different models that have been tried. I don't know that anyone has a perfect answer to that. It's such a complex problem. I think we do need to find a way to decrease the cost of care. There's no question about
Right.
that. Spending more and more of our GDP on health care, it's such a problem in limiting all of the kind of things we can do.
Why are the costs
economically.
as high, Dean, as they are?
There are many, many parts of that. Take on one part of that. The population, if you're insured and you look for care, right, it is not relevant to you in a sense of what the costs of that care are. It's a principal agent problem, basically. So that I'm insured, then I am not paying my dollar for that. So people are incentivized to use greater amounts of care. At the
Right.
same time, there's not transparency in price of care. So if I'm an individual looking to buy health care, I don't know what the system costs of that are. And I am in a position as a healthcare consumer of being to some degree in a position of power inequity with the healthcare system. So what I need as a consumer is more control of the dollar in my pocket. And I need the ability to shop that from place to place to find the most efficient and the most cost-effective health care for me. So what does that take? It takes innovation, to the senator's point. It takes the ability for the consumer to be better educated as a health care consumer.
And that requires more transparency on price, right?
Transparency on price and transparency on outcomes.
Right.
And with those data in mind, now the consumer can make wiser choices. So that's one thing that could be very important at helping to decrease this steadily increasing cost of healthcare.
Do you think there's sufficient competition on insurance right now? Do we need to rewrite the rules to create more of a marketplace for people to choose providers?
I think competition in healthcare is good.
Yeah.
So I think to the extent that people have a choice of providers, of insurers, of physicians, yes, I do think that that's good for healthcare.
Well, and the other part of it, Dean, I have to believe, is that the delivery of care has changed in our lifetimes, right? And so technology is part of the conversation, and just the approach to treating people is different. So possibly, if the system were built from the ground up today, you might in fact have a different system that addressed the patient of today as opposed to a patient of 25 or 50 years ago.
Well, I think there's no question that we need to invest in primary care services.
Right.
And we need that individual to have healthier choices,
Yeah.
healthier food options.
Back to the senator's
points.
Right.
And to be able to really be involved in preventive care from the time they're born. The insurance system makes that difficult because people change insurances.
Yeah.
So to the insurer, it's not worth investing in that kind of care because they figure that at some point someone's simply going to be on another plan.
Right.
So you need an insurance system that incentivizes health, not disease.
Got it. Let me go back to Congressman Vela. So there's a conversation around single payer that is popping back up in Washington. So we're talking about the possibility of repealing. Let's now go back to the other side, and let's say that maybe what we ought to do is depress the accelerator in terms of providing health care. Not get out of the business of providing health care, but get super back into the business of providing health care. Do we need to do something more radical on the left of where we are as opposed to on the right of where we are?
Well, I don't really know the answer to that. What I do know is that
You're not a member of Congress coming out for single payer.
when I have come out for single payer.
You are.
Yeah, and I think that when you consider the statistics we talked about earlier and the number of people that are uninsured and who require access to health care,
Yeah.
that we do need to start thinking in those terms.
Yeah. You think it's politically possible at the moment?
No.
It's difficult, isn't it?
Right.
Yeah.
Right. Speaking of politically possible, let me ask Representative Longoria first, and then Senator Hinojosa. We alluded to Harvey, talked about Harvey earlier briefly. Senator Hinojosa is correct. The state budget for 2 years, all in, is $217 billion. The cost of the Harvey rebuild itself is going to be as much, if not more, than the 2-year budget for the state of Texas. Now, the federal government is, probably a lot more significantly. You know, how many of us have made a deal to build a house and they give you a bid on the front end? How often is that bid good on the back end, right? It always costs more. And the rebuild's going to cost more than they're predicting once we get to the back end. Now, the federal government said they're going to pay for a significant part of it, but already we're hearing that we don't know when the money is coming, and there's reason to be skeptical, if not cynical, about the degree to which that support is coming. And the White House said the other day, Representative Longoria, one of the reasons that we're not getting more money as we've requested is because the state hasn't put any money in out of the state budget yet. The White House is complaining about that. How is this going to affect this conversation heading into the next session?
You know, at the end of the day, we have limited resources. We have our state budget, we have certain constraints, and whenever we have to pay for something, you know, something's going to get cut.
And especially something unanticipated as this was.
Exactly. We didn't anticipate it. And then at the end of the day, you know, folks say, well, you have the rainy day fund. I said, that's a drop in the bucket when you really look at the expenses of Hurricane Harvey.
That would only, even if you took every dollar out of the rainy day fund, it would only be about $10 billion.
That's correct. And it would just be a drop in the bucket. What needs to happen is I think we need to allocate our state resources to get the most bang for our buck. And what I mean by that is maybe working through GLO, making sure that folks are opening their FEMA cases. We're starting to get decision letters, and these folks are getting decisions on whether or not they were accepted or denied and whether they have to modify their claim. Those folks need help. We're seeing a lot of folks that have moved and been displaced and initially opened up their FEMA claim, so we need to make sure we address that, and we need to focus our resources to make sure we get the assistance we need from the federal government. And I think when we go back in 2019, if I'm there, we'll go back and look at that and see what we can do to backfill. But ultimately, it's going to have to be a partnership between the federal government and the state.
You confident that the federal money is coming?
I'm optimistic it's going to come.
Optimistic is not the same as
Well,
confident.
I will tell you this. I was at a hearing last week in the Corpus Christi area, and they were discussing the fact that only one FEMA trailer has come since Hurricane Harvey in that whole Rockport, Fulton area. So that is dire. And I'm hoping that we can go ahead and try to work with our federal partners.
Feels like we've seen this movie before. Past hurricanes, we had sort of a similar, right?
It's the storm after the storm.
Right. And you know, Representative Longoria, that going into next year's budget cycle, or next legislative session cycle, the one that would kick in on September 1st of 2019, we were already expecting a difficult budget cycle because we had kicked the can down the road on a bunch of costs already. So Harvey only makes a bad problem worse as far as the state budget goes.
That's correct.
And so if healthcare is pushing out more things each time and we have the Harvey problem, it's going to be a bad session from a budget standpoint.
Of course, and ultimately with healthcare, like I told you, it's more of a policy issue. I think we need to make sure where we can incentivize and reward quality care.
Yeah.
We need to be frugal, but we need to make sure that we don't cut corners because we need to make sure that we have a healthy Texas. And we always speak about the population down here, that many of the kids are on CHIP or Medicaid. Well, the fact is there's a lot of uncompensated care. You know, folks like DHR, all the healthcare providers, I commend them because they're taking a risk every day. I mean,
Right.
the population down here in South Texas is very different. I mean, Senator just mentioned it in comparison to the Dallas metropolitan area, Houston area. And the fact is we're dealing with a population that is indigent, but we still need to provide health care for them because those children need to go to school and they need to
Yeah.
get educated because that's the only way we're going to progress.
You have the benefit of having, as I said, Senator Hinojosa, been in the legislature for a long time. You're a veteran member. You've seen budget cycles come and go. This is not going to be a good budget cycle, is it, because of Harvey?
Well, every budget is a challenge.
Yeah.
You know, we always underfund Medicaid by about $1 billion plus, and come up with a supplemental budget every session to make up the shortages in funding. But obviously, we've also, through the vote of the general public, we have made funding for transportation a priority because we get a lot of complaints about toll roads, about potholes, and quite frankly, just the cost to drivers in terms of repairs to the vehicles.
Right.
But here's what it is. This issue with Harvey Hurricane, it is not something that'll get resolved in one session.
Yep.
It's a long-term cost that'll be there for years to come. We're talking about easily probably over $200 billion, maybe more. But the cost is a shared responsibility. It's not only the federal government, state government, but also insurance. A lot of this damage that was caused was covered by insurance. Sometimes we forget about that. For us, the money we have in the rainy day fund, the $11 billion, quite frankly, as compared to the cost of Harvey, I mean, it's a drop in the bucket. So we got to manage the process. I know that every session, it's really an amazing process, but just every session we have done it.
Yeah.
And we try to also focus and reduce funding for certain, quite frankly, projects that are no longer a priority. So it's a process in itself.
Are you worried about where the healthcare cost curve goes in a budget like this, and whether we can make enough money become available?
Look, healthcare. To me, healthcare is a necessity, not a luxury. And sometimes when we talk about healthcare, we forget to mention the responsibility of local government. I'm talking about the counties. In the 1980s, when Mark White was governor, we passed legislation to deal with indigent healthcare. We required counties to set aside 10%, later reduced to 8% of the county budget to be dedicated to health care for indigent. What has happened now is that we didn't provide for any enforcement mechanism, so you have counties reducing the amount of money they appropriate for health care. And I'll use Hidalgo County as an example. In the past years, we had up to $18.5 million set aside for indigent health care. Because of the 1115 waiver, we were able to multiply that and have 3 times that amount.
Right.
Figure out the math, 40-something million. That 18.5 million has been reduced to 5.5 million. Think about that. So we left about $12 million there on the table. Multiply that by 2 to 3, you got $36 million that sat there that could be used for indigent care here in Hidalgo. So, you know, it's a complex issue. For us in the state, obviously we worry how to contain and control the cost of health care.
Dean, let me pick this point up, and we're going to take questions from the audience here in a couple of minutes. Let me encourage you to come to the microphones if you would and line up, and we'll call on you here in a second and get to as many as possible. Dean, you mentioned the desire to see more funding come to the medical school. Senator Hinojosa talks about the reduction in the budgeting for indigent care. You're practically begging me to bring up the healthcare taxing district question.
Yes.
Which I know is a matter of no controversy whatsoever down here. Not controversial at all.
None.
The fact is that the impetus for this initiative, which did not succeed, but presumably could have another life at some point, was that we need to figure out a mechanism to put more money into the healthcare system to both offset some of the costs of indigent care being borne by various entities and also to provide more funding for the medical school. It would be a Pyrrhic victory to have built the medical school, but then not to have realized its potential without adequate funding. So can you make an argument? You're new to the scene, but you're also new to this fight. What should this community think about the potential for the healthcare taxing district coming back up?
Well, essentially, we are the only community in the state that does not have a healthcare district. That we have the largest uncompensated burden in the state. We have a large number of people who are underinsured. The only way that we are ever going to get that under control is to have the local communities, through a health district tax, begin to step up to the plate and assume their responsibility. And it is something that it's the public's responsibility. It's an ethical and moral responsibility to do that. We need to find the mechanisms that people will accept for that. The medical school, in my mind, is the right conduit to make that happen because we have the will and the staff and the programs to be able to get into the community and do that. And we certainly want to work with our hospital partners because they provide the care that the medical school can't do. They
Right.
provide inpatient care. They provide procedural care. So the health district needs to be something that the residents of the county accept as a responsibility, and we need to find a way to work with our institutional partners in this area to make sure that that happens. For us.
Congressman Bailey, you know that no one wants to pay more taxes. Just as a matter of course, people would rather pay fewer taxes than more taxes. So anytime you talk about even a modest increase to fund good things, you've got to sell people on their self-interest, right?
Right.
Why hasn't the effort to pass such a taxing district succeeded to this point in persuading people that it's in their self-interest to do it, if it is in fact in their interest?
Yeah, that's a very difficult question for me to answer because we've had that vote arise on two separate occasions.
Right.
And the message from proponents of the taxing district have been very clear about the benefits that it would have for the people that live here, yet it still fails. And I supported it the last time.
You'd support it again if it came back
I
up?
think I'd support it again. We'd have to kind of see in what context that would arise, right?
Right.
But when you consider that now we have a new medical school, we've got a bunch of new doctors that are being trained, that I think we really have to take a new look at that.
That's kind of the way in. Usually the medical school is kind of the leading, the blocking back for this.
Let me add to that because it's important to understand that possibly we should just focus on the medical school being part of the healthcare district. And
leave the indigent care budget off the table?
Correct. The other mechanism by which we bring down the indigent care money, as long as the 1115 waiver is there. But the county also has the responsibility, and it's in the statute, that they need to shift 5 cents or 6 cents the property tax that they impose over to the healthcare district. I mean, that problem is resolved.
Yeah.
But it's hard because, quite frankly, we don't. Again, while it's in statute, the county has to step up and transfer those tax dollars to the healthcare district to deal with the medical school, so they can triple through other federal matching funds and have the proper funding for the medical school.
Yeah.
And here's one of the key things. And I said a while ago, the medical school is a game changer. If you look at San Antonio, and I will use that as an example, when the medical school was created, it's created in northwest San Antonio. It was nothing but farmland, ranchland. It is now 30% of the economy in Barrow County, San Antonio. It will create thousands of new jobs.
Right.
It will bring health-related businesses to the valley. Plus, also the jobs will not be minimum wage jobs, but more important,
they're high-paying jobs.
It will attract a lot of private research funding and federal funding for us in the valley. It just, the amount of doctors and the specialties will be enormous, and that is the investment that we're making for the future and for our children. I mean, it just sometimes.
But again, I'll ask you the same question. If you've been a big advocate for this in the past and it hasn't gotten done, why do you think it hasn't gotten done? What didn't happen that needed to happen to get this done?
Well, my view is it probably to put too much. Too much for the healthcare district to be able to do. You have to keep it much more narrow, much more focused, just the medical school.
And if you make it only about the medical school, possibly people will support it.
I think you'll have a much better chance of passing.
Okay.
And get the county to transfer the funds.
Let's go to questions from the audience. If you have questions, please come up to the microphone, and I'd be more than happy to. Anybody who asks a question not about the healthcare taxing district, I'll give $1 to. How about that? Last time we were here, it was like 3 deep on that subject. I have no doubt, ma'am.
Well, first off, I would like to ask, how much do you make a year? Each of you, I know 3 of you are politicians, and 1 of you is the head of the medical. The average citizen out here cannot afford the hospital district. If the county paid their 8% of their budget they're supposed to pay to the indigent care for our 5 clinics, it would be taken care of. So y'all built the medical school. Y'all pay for it, not the taxpayers. 111,822 voted no. And I'm hoping that those same people will look when y'all are running, because today y'all are pushing, I think we'll have to do the medical school. You're going to rename it. The people out here are not stupid.
What is your question?
So my question
Yes.
is, why do you keep bringing it back to the people that y'all represent?
Well, the first question I have for you all, to her point, is she said the taxpayers did not pay for the medical school?
Yeah, we didn't vote for it, and we're not paying for it.
But ultimately,
so.
taxpayers did pay for the medical school, did they not?
Yeah, well, here's what it is, Fern. And the problem is that every medical school cannot be paid solely by the state. We don't do that. It's a combination of local healthcare districts and the state and the federal government and private investment. So it's got to be a joint effort. I will also tell you that the cost is still there. It doesn't have to be through maybe property taxes. When you go and have somebody that needs medical care, and the only way they can get is going through the emergency room, which increases the cost of health care, well, guess who pays for it? Those of us who can afford insurance, or those of us who can pay for health services. So it is a much more complicated issue than you make it sound. It's obviously, to me, last time we had other programs involved in the healthcare district ballot. I think if we just focus on the medical school, period, it will work.
Sir.
Right, thanks. Thanks for being here. First, I'd like to remind everyone that the VA system of healthcare, which is a disgrace, is a single payer. I believe that the dollars in healthcare should be going to take care of people and not to enrich executives of large corporations. And I wish the government would feel the same way. And I'll give you a perfect example. In this country, 75 to 85% of the medications distributed are generic in the general population. But in the Medicaid population, 65% are brand name. In the state of Texas, the #1 drug that's prescribed is antipsychotics for children for a brand name. That's the #1 drug that Medicaid pays for in the state of Texas. Brand name.
Right.
That is why, even though 89% of the medications dispensed are generic in the United States, the federal government and state governments spend 4 times as much on brand names as they do on generics.
What's your
now
question?
The question is, I think it's pretty obvious. The fact of the matter is, why is it that it's perfectly acceptable for the private sector and people with commercial insurance to get generic drugs, almost required to do so, but in the government sector, they're required to take brand name? To me, this is nothing other than a boondoggle for the large pharmaceuticals, and I'm sure that has nothing to do with the fact that the biggest lobbyists in Washington and at the state level are pharmaceutical companies.
Pharma. Congressman, what about that? That seems like a reasonable question.
Mm-hmm. Yeah, and I think you're right. I mean, I think that the problem is with the focus on a full repeal of the Affordable Care Act, we haven't been in a position where both sides of the aisle have been able to address that directly. So I don't disagree with you.
Well, there's nothing to disagree with. That's a decision that's made by the government that requires prescriptions for Medicaid patients to be disproportionately shifted towards brand name.
Okay, so then a change in that policy is what you're advocating.
That doesn't
for, obviously.
require a statute. That's simply regulatory.
Right, well, the
And I don't know
congressman
what
is
that
only,
has to do with the
congressman is only
Affordable
one
Care
of
Act.
435 in the House. He can't fix it himself, but he says he's for that same idea. Right?
Right, that's right.
You're for it. Okay.
Yeah.
And I'm for it. I'm for it too. I think it's important to go ahead and look at what's happening. We got to make sure we don't focus too much on the administrative costs because that money needs to flow down.
Does the state have, Representative Longoria, does the state have anything to say about this gentleman's question? Can the state make a decision as far as which medications are required?
I think it's something that we wanted to look at this past session. I think it's something that we're going to look at, and I think ultimately we need to kind of go and see where we're getting the most bang for our buck, and we need to make sure that those costs aren't staying at the administration level, but rather flowing down to the actual providers, which are here in this room.
Yeah.
I don't think on the Medicaid,
Yes.
federal law, they allow states to negotiate prices with pharmaceutical companies. If they did, we could negotiate a better price.
Right, but not right now. We can't do that now. Sir.
Okay. Good afternoon, gentlemen. My name is Rogelio Alaman. I'm a local veterans advocate here in the Valley. My question is to the congressman. According to the medical side of the VA, we have longer wait times. To give you an example, my father went to the VA clinic at 8. He just barely got out like about 10 minutes ago, and that was a walk-in. Congressman Vela, what reforms would your office bring to fix the medical side of the VA to help our Valley veterans who are not getting
Right.
adequate health care?
This is
Yeah.
a persistent problem, is it?
Yeah, it's a persistent problem, and we've been dealing with it ever since I got to Congress, and we deal with it in my office every day. On average, I would say we have 10 to 20 veterans in the same situation as your father who come to our office seeking help navigating the VA clinic system. And I don't have the exact answer to it because we've brought Senator Cornyn down here, we brought the Secretary of the Veterans Affairs here, Bob McDonald 2 years ago, and now we have a new administration. Part of the problem is we haven't been able to address the Veterans Affairs situation this year because we've been so focused in Congress on the Affordable Care Act, repeal, and now tax reform. But saying that, it's a very complex issue, and I think one of the things that we have seen inside the veterans clinics is there's a large turnover of physicians at our local veterans clinics. So the veterans clinic will hire a doctor. They come in from out of town. They may be from Pennsylvania or Florida or somewhere, and they're not used to living here. They want to go back home. So all these appointments are set up in advance. The doctor leaves, and all of a sudden there's nobody to replace
Is
him.
there not a better way, Congressman, to provide health care to veterans who have done so much for this country? I mean, it seems like an elemental question. It seems like it ought to be a priority of the federal government to provide health care on the back end after all their years of service. Why can't we get this right?
I really don't know the answer to that. I do know this, is that for the past 3 years, as many veterans as we have seen come through our offices,
Right.
The system is in no way perfect, but over time we have seen some positive changes, but it's a very difficult
Obviously
issue.
not enough. Dean, is academic medicine in a position to provide some help here?
Academic medicine is a partner of the VA around the country, and in many VAs throughout the country, it is the academic medical centers that provide the residents, provide the faculty. And I was at a meeting with Secretary Shulkin recently, and he pointed out that where academic medicine is involved, they are higher functioning. They have shorter wait times, they have better quality of care. So this is certainly an opportunity for us to partner with our local VA, which is one of the poorer performing
But that's not
ones.
something you're doing now.
It is not, and the incentives are not there for us to do that. It can be a challenge in doing that. And part of the problem in privatizing in the local is that I'm very aware that many people have large amounts of money they're owed from the VA system where they do provide care at the private level. So we need a better system where we can provide the care for the veterans who badly need that care, but then the providers find an easy way to get reimbursed.
Can't get
and not
stuck
have
with
to-
the bill.
Right.
Yeah, sir.
Thank you. Thank y'all for being here. My question, during the last legislative session, I know Senator Hinojosa supported a bill that passed its way through the House, similar to the LPPF, that would have drawn down federal funds and supported long-term care for seniors. My question is, what do you think about the future of next legislative session of something like that happening?
I'm assuming it didn't get
It didn't make
all
its
the
way.
through.
It didn't make
It's
its way
about
out of
the
Senate.
long-term care for seniors, that you were supportive of legislation in the last session, didn't make it through. Do you think that that has a chance of coming back next time?
You're talking about nursing homes, right?
Yes, sir.
Yes.
Yes. What we're trying to do is create like a system where nursing homes could draw down 11, 15 waiver fund. The answer is yes. I think there's going to be a very strong push. Nursing homes, quite frankly, don't have sufficient funding to provide all the care that our senior citizens need, and they have the shortage of staff. So it's very important that we come up with a system where we can provide additional funding. And the bill that I carried on the Senate side had a mechanism by which nursing homes they themselves put up an assessment fee, which then they would double and triple with matching funds from the federal government. Keeping in mind that it's like the local participation provider fund, but at a statewide level,
Yep.
The same concept. So yes.
Thank you for your question, sir.
Yes, sir. My name's Eloy Pulido. And Senator Hinojosa, thank you very much for being here with us today. There's a couple of questions that, one that I believe need to be asked is, first one being, as far as the educational system, why are we not doing a better job of identifying those kids that are high risk for diabetes because of family history and other factors, where we can start tracking some of these kids in order to identify a potential problem. But also, Senator, something that I think is very, very important also is the fact that Senator Lucio has introduced legislation several times where the Lone Star card can only be used to buy certain foods. Where you eliminate the junk food, you eliminate some of these foods that are really just perpetuating the problem.
Yeah.
But yet, big business always manages to get in there, and it doesn't even make it, doesn't get out of calendars, and is never even discussed. But yet, our government, state and federal, spends billions of dollars just between Starr County and Cameron County and Hidalgo County in between, but yet nobody seems to care about actually addressing the issue,
Right.
as opposed to letting big business continue to make the billions of dollars.
This gets to the point you were making earlier, that if we could somehow get out in front of these health problems, that you could avoid some of the costs you're incurring on the back end. And I don't know about Senator Lucio's bill, but is that something you've supported?
Yeah, I did, and I support that, Mr. Pulido. I think what it is that we need to, quite frankly, try to put parameters on the type of food that you can buy with a Lone Star, so you eat healthy food and not the what I call the junk food that really is not healthy for the body. The other issue with high-risk kids, public schools do that, and they're supposed to report them to the proper agency for help. And quite frankly, the real we appropriated $10 million last session before last. This time around, another $8 million. We created Healthy South Texas, where we have a system in place coordinating the medical schools, the pharmacy schools, dealing with the hospitals, the doctors, to try to provide and teach and educate families how to eat healthy and how to stay physically fit to be able to try to reduce on a long-term basis diabetes, obesity, some of the infectious diseases that we have. So we move in that direction, preventive type of help.
Senator, one last thing. Back in 2000, Senator Lucio introduced Senate Bill 1615 that created a health services district for Hidalgo and Cameron County. It was a by-district effort, or a by-county. And what it called for was the 8% of the budget going for indigent health care but taking that money to leverage tobacco settlement money. My understanding is, but yet it prohibited any new taxes from the public or any entity, and it was going to be solely tobacco settlement and indigent healthcare money. Maybe we can start looking at that, Senate Bill 1615.
I co-authored that piece of legislation along with Senator Eddie Lucio. That district is still in the books. Apparently, they were supposed to shift over 8% of the county budget over to the healthcare district, or it was just a health district for taking care of indigent care. Something happened in terms of the board members that were appointed and friction between the county commissioners.
Imagine that.
And they ended up just pulling the funding.
Maybe it's something we need to revisit, Senator.
We are looking at it.
Oh, okay, good. Thank you.
Yes, hi.
Hello, my name is Hilda Solis, and I have a few comments in which then I'll pose a question. One of the comments was earlier was regarding why Texas Medicaid only pays for brand name for children in mental health. And I can say that one of the reasons is because very few psychiatric medications are prescribed or indicated for children and adolescents. So we've had research in the last maybe 5-10 years, and these medications that are branded are not generic yet. So we're hoping down the road there'll be some generic meds.
All right.
Number 2, with the VA, we talk about getting ahead of the game and treating them on the site, on the scene. For example, World War I and II, we had a lot of shell shock where the soldiers went untreated. We treat their physical wounds on the scene. We don't treat their mental issues on the scene. And Dr. Stephen Stahl has some great issues regarding how to get ahead of the game and treat them on the site so that we prevent a lot of PTSD and the flow that comes afterwards.
All right.
Number 3 is regarding, yes, we need the medical school. Yes, we need a healthcare district. Yes, we need more physicians. But also I wanted to point out that we have a group of nurse practitioners that are ready to fill in the gap.
This
We
is the
just
scope of practice conversation, right?
Right.
Yes.
We just need a little bit of leeway in order to do that. So my question to all of you is, what can you do to promote some of these things to occur?
Representative Longoria, the scope of practice conversation, expanding the pool of people who are in a position to contribute to the solving of this problem, and the telemedicine conversation, another issue, telehealth. These were both somewhat controversial in the last couple sessions, were they not?
They're always controversial. I think we need to look at what other states are doing, kind of look at those examples, and if it's working in other states, it may work in Texas, and especially for those rural areas. Those nurse practitioners are very efficient and very valuable.
Yeah.
There's also issues having to deal with optometrists and ophthalmologists. I mean, it always comes up. I think we need to kind of see what everybody else is doing, and is it being efficient? And if it is, then it's something we need to look into and open up the scope for those individual professions.
There's 24 states already there.
Dean Krause, on the telehealth question specifically, we were talking about the shortage of doctors in a lot of counties in Texas. One potential solution is to make technology your friend, right, in giving people access to care.
Absolutely, and telehealth has been used in rural areas and patients with poor access to care very successfully. You can see projects throughout the Midwest and the Dakotas and elsewhere. It's certainly something we should do more of, but back to your point, I 100% agree with you that basically if you look at where healthcare of the future will be in team-based care. And if you look at all the population health initiatives that are out there, it's saying that people should be used to the maximum of their license. And as we develop outreach, preventive care and primary care, it's got to be in patient-centered medical homes. It's got to be in team-based care, where you have physicians and nurse practitioners, physician assistants, nurses, dietitians, social workers working together in teams, because that's how you'll decrease cost and improve access and quality. So I totally agree with you.
Okay, our last question is going to be from over here.
My name is Tania Chavez, and I'm with La Unión del Pueblo Entero Lupe. Our organization and our membership support the healthcare district, and we did so because we understood that in Hidalgo County, we lack a public hospital. So the healthcare district would allow for a partnership with the community health clinics, with the private hospitals, and the university to be able to solve the amount of uninsured in our county. However, you are proposing to reintroduce a healthcare district where it would only help fund the medical school. And my concern will be, how will that then help reduce the amount of uninsured that we have in Hidalgo County? Because the bottom line is, yes, we need to support medical school, but we also need to be able to provide health care, immediate health care for those who need it.
Let me ask Senator Hinojosa and then the dean to say, how will that benefit the uninsured problem in it?
Yeah, I mean, first of all, funding just the medical school to the healthcare district doesn't mean that we don't fund the 9 clinics that Hidalgo County has to provide health care. In addition to that, doesn't mean that the hospitals don't get 1115 waiver funding and there are a lot of federal programs that will be available to fund for indigent care. So the fact that the school district will be the only funding mechanism or the only recipient of funds through a healthcare district doesn't mean that there will be no funds available for indigent care or no funds available for healthcare clinics to provide healthcare to the general public.
Dean, what would the medical school be in a position to provide if you were adequately funded to get at some of this?
We work closely with a number of our community partners. We, in fact, have 11 sites that we reach out to in community centers.
Yeah.
We work across the valley from La Victoria to Bob Clark. We have a van that goes out to these sites and provides mobile health care. We'd be able to adopt more vans. We have family physicians we would be able to hire more of so that we can go out to all 11 sites and not just the 3 that we're starting with in the AHEC groups. We got a federal grant to provide service in these areas, and we can continue to leverage these dollars to attract more residents, more physicians to the area that will allow us to go out to all of our community partners and provide care in the community where it's needed.
All right. Okay, we've hit 1 o'clock. I'm afraid we're out of time. I want to thank Senator Hinojosa, Representative Longoria, Congressman Vela, and Dean Kraus. Please give them a big hand. Thanks to all of you for coming, and we'll see you again back in the Valley. Happy holidays.
Yep.
Thank you.